Hello my friends, welcome back to my channel in the new video, and this is a continuation of the debate on albumin which I talked about of albumin not being used routinely in ICU. So this was a safe TBI trial, the post hoc study of about 460 patients with traumatic brain injury. The fluid resuscitation with albumin was associated with higher mortality rates than was resuscitation with saline. So this was a glaring, difference in the mortality of both the groups, and we'll see the reasons for that was a hypotonic albumin was used, which worsened the cerebral edema in this particular group of patients. There was documentation of high ICP in albumin group with evidence of fluid overload. There was disruption of blood-brain barrier which causes extravascular osmotic load, and there was no compensatory physiological benefit of albumin. So these were the reasons for the high mortality which was seen in albumin group. What about sepsis and septic shock? So these are the surviving sepsis campaign guideline which suggests for adults with sepsis or septic shock use of albumin in patients who received large volume of crystalloids. Only for those patients who have received large volume of crystalloids. Although the definition of large volume is not mentioned, but by and large we know that when we have a cumulative balance of about 5 liters in 24 hours, then yes, you may consider albumin, and there is a suggestion on that. This was another paper which came out from China with a comparison of the effects of albumin and crystalloid on mortality among the patients with septic shock. It was a systematic review with meta-analysis and trial sequential analysis. And the conclusion was the results from this meta-analysis showed that in comparison with use of crystalloid, human albumin did not decrease all-cause mortality as evaluated at the final follow-up. The trial sequential analysis results suggest that the negative results observed so far might not be definitive. Further RCTs are needed. But it still suggests few signals against the use of albumin in septic shock as a routine strategy. And what are the adverse reactions or the possible threats which we all should be aware as regards albumin is of course fluid overload, pulmonary edema. There is some literature which points towards potential AKI after albumin infusions, and of course the cost, which I have actually already discussed, and allergic reaction as it is a foreign kind of material. And of course there is a potential possibility, a minuscule possibility of transmission of infection. So this is all about comprehensive side effects of albumin profile. And the attire trial got published in NEJM 2021, which talked about another subset of patients of cirrhosis who were hospitalized, and it was a randomized multi-center open label trial which compared the standard care group and the albumin group. And as you could see that the primary outcomes, the infection from any cause, kidney dysfunction and death during hospitalization is almost similar, and the secondary outcomes of mortality at 28 day and 3 months were also similar without any statistically significant criteria. So what are the futuristics? There is Albus study which is coming out. It's a randomized controlled trial where human albumin for resuscitation in surgical septic shock patient are to be enrolled from December 2025 to December 2029 with a target albumin of about 3.5 grams per deciliter. Primary outcomes of 28-day all-cause mortality and secondary outcomes involving length of the stay, ventilator-free days, AKI, and adverse reactions. So these are the few of the futuristics. And as far as the stewardship is concerned, as I was discussing, we need to have order controls, the guideline integration, taking into account the recent surviving sepsis guidelines, or other guidelines which actually can be integrated in your policies and protocols. There should be regular audits, feedbacks, and of course, education and training forms an important part and parcel of use of albumin in your hospital or ICU. So, why will I not use albumin? Because of many reasons, starting with no mortality benefits, and it has been proven beyond doubts in safe and albus studies, and including the meta-analysis which I shared. High cost. So there's definitely that we need to take into account. Without the outcome advantage, I will definitely actually not be very pro for a regular and a routine use of albumin, barring the standard indications. It gives a false sense of superiority and does not translate to better outcomes. It has inconsistency with subgroup driven benefits, and it will definitely cause potential harm with guidelines having weak recommendation or conditional recommendation, so as to say. So this is all about albumin as a con aspect of albumin in ICU. I hope it is of some use to you in your day to day practice. That's all for now. Thank you.